Hello professionals, this is Dr. Saad and as you know we are recording series of lecture for pharmacists who are going to appear for international equivalency exam, and recently we released a series of lecture on nervous system, and we as you know it has two major division, central nervous system and peripheral nervous system. In peripheral nervous system we recorded a series for on the topic of autonomic nervous system, which is a vital part of nervous system, and recently we finished about a series for the central nervous system. And once you go and check our playlist, you will find all relevant videos regarding that. It contain all important points which play a very important role, or you can say all abstracted points which is very important for the exam point of view. It contain an abstractive points. So let's begin our new system, that is the endocrine system. And first of all, I will give you a brief introduction, then we will discuss it in a detailed way, an abstractive point and a summary. The same pattern would be same, like we will discuss all important points, physiology, and its clinical points, and in the end we will give you summary. And when we will conclude this system, in the end we will see prescription oriented to the endocrine system, like share of prescription which endocrine system oriented pharmacological drugs play a role for the management or keep our body in the in a specific balance with respect to enzymatical deviations. So let's begin our topic. As you know that our body has two complementary systems. First one is nervous system, whose lecture earlier has been delivered, and second is the endocrine system. As long as the endocrine system is concerned, this system has authority to control the reproductive system, growth and development, homeostasis, metabolism and energy balance, and body defenses. So unlike to the central nervous system, it use specifically, you can say exclusively, blood as and more as a transport media for the transmission of signaling and coordination process among various enzymes, and to perform their physiological activities. So it has various enzymes and various glands and various hormones to control and coordination and production, and to perform various physiology. So we will discuss them separately. But for you, just for an information, that our brain's hypothalamus, brain's one major part, whose name is hypothalamus, it work in close coordination with it is with the one of the master gland, that is known as pituitary gland. These two, hypothalamus and pituitary axis, controls and stimulates and performs some activity directly, and sometimes they use stimulants to induce other hormones to carry on their activity. For example, as you know that the hypothalamus releases GHR, and that is the growth hormone releasing hormone, thyroid stimulating hormone, corticotrophic releasing hormone, and GnRH gonadotrophic releasing hormone, to control the function of control the functions of our thyroid hormone, as well as corticosteroids, that corticotrophic releasing hormone. Through corticosteroic releasing hormone controls specifically our catecholamine production, as well as through GnRH it controls the reproductive system, and through growth hormone it controls our body functions. Similarly, there is a part, as I told you, about the pituitary. It works in close coordination with the hypothalamus, and it has two major parts, that is the anterior pituitary and posterior pituitary. Anterior pituitary releases GH, and there is growth hormone and thyroid stimulating hormone and adrenocorticotropic releasing hormone and luteinizing hormone and follicle stimulating hormone and prolactin. And posterior pituitary release ADH, that is the antidiuretic hormone, and oxytocin. The hormone play a very important role for endocrinology, and it controls the glands, liver, bones, and other tissue body function, our tissue related functions. So in this way, it controls basically pituitary gland, thyroid gland, adrenal glands, pancreatic glands, gonads, and other body functions which are associated with respective glands. Sometimes it directly controls the function, sometimes it induces other hormones, like anterior pituitary releases thyroid stimulating hormone, or hypothalamus releases thyroid releasing hormone, which induces thyroid hormone to produce thyroxine. So in this way, they regulates our body function. So this was an brief background of this our endocrinology, and just a brief review. We will discuss each and every gland relevant to the physiology, pharmacology, and therapeutics, and exclusively we will discuss all these topics so that we can have a command on our basic pharma, so that we can understand the principle on which we draw prescription for various deviation in, or you can say in various conditions in which hormonal imbalance is playing a vital role for ailment of patients. So let's start our first topic, that is the thyroid gland And before going into any irregular detail, let me tell you simply that its anatomical position is anatomical position, or you can say anatomically spotted at in front of neck. And let's discuss about its biosynthesis of thyroid hormone. Thyroid hormone, there is iodine play a very important role, or you can say it regulates the production of thyroid hormone, because it is transported into the thyroglobulin by iodine's importer, through which, after passing iodine organification steps, it in thyroglobulin, it produces finally thyroxine, which is available either in T3 form or T4 form. T3 triiodothyroid is more potent than that of tetraiodothyroid. The majority of its portion of tetraiodothyroid, that is also known as thyroxine, is metabolized peripherally, which is ultimately converted into the more potent form, that is the T3. But smaller portion is also metabolized in the thyroglobulin, and it is converted into the form of T3. So whatever it may be, ultimately the final product that is required for physiological functioning of thyroid hormone is the T3, that is triiodothyroid. One thing I would like to let you know about a name of enzyme that converts T4 to T3 is the mono deiodinization. This process is known as mono deiodination, and the hormones, or you can say enzymes, which play a role in it is known as D1, D2, and D3, which converts ultimately T4 to T3. This process of biosynthesis of thyroid hormone is regulated by the iodine. So where iodine is very important for the production of thyroxine, as well as, on the other hand, we can regulate hormone by the use of this iodides. For example, when concentration of iodine are very high, then it inhibits the production of thyroxine, because it inhibits the iodine organification steps. So we will discuss in later points that how we use iodine's media for the controlling the level of thyroxine when it is going towards when we want to get our various objectives. So let's move on and start our points. But before going into points, I would like to let you know some factors and some drugs which in peripheral system, or in thyroglobulin, inhibits the conversion of tetraiodothyroid to triiodothyroid, or in short word, it inhibits the conversion of T4 to T3, or in other word, it actually inhibits the production of more potent thyroxine, to that ultimately impact on the function associated with thyroid gland. So these drugs are amiodarone, iodine contrast media, beta blocker, corticosteroids. These are the drugs which inhibits the production of T4 to T3, metabolism of from T4 to T3. So similarly, there are other factors like severe ailments and starvation. These factors also play a role for the inhibition of metabolism of tetraiodothyroid to triiodothyroids. So this was all about our brief review on biosynthesis of thyroid gland. Let's move on. Let's move on and see where does our thyroxine, and what are the impacts produced by the thyroxine in our body, and why it is so important. As you know that thyroxine play a very important role in functioning of nervous system, skeletal system, and in you can say reproduction, tissue, and metabolism, as well as degeneration and secretion of other hormones, including catecholamine, cortisol, estrogen, testosterone, insulin, and you can say insulin is also affected by the thyroxine level. Similarly, there is other impact that is known as thyroid hormone is responsible for the protein synthesis and increase the activity of sodium potassium pump to increase the oxygen consumption, and stimulate the secretion of other growth hormones. So briefly, it play a very important role because it is controlling nervous system, skeletal system, and catecholamine, and cortisol, estrogen, testosterone, and especially insulin is being impacted by this hormone. So we'll discuss one interaction with the insulin. In this, we will talk about this interaction and how do it affect the insulin. So this was all area of influence of thyroid hormone. Let's move on our points, as we had been discussing in our previous video of central nervous system and autonomic nervous system, that we instead of going in detail topic to topic wise, we just focus on specific points. Let's talk about point number one, that is the precursor of thyroxine, that is the tyrosine. Tyrosine is the precursor of thyroxine. Point number two is the iodine. For the regulation of thyroxine secretion, and it is actually regulated by the iodine level. I just want to let you know that uptake of thyroid gland is inhibited by the high iodine dose. So major action of iodine is to inhibit the release of thyroxine because it actually blocks the iodine organification steps. That's why in thyroidectomy, prior to surgery we use Logos solution as well as potassium iodide. This point we will discuss in detail that when there is a chances of hyperthyroidism, we will actually control the level of thyroxine. And in hypothyroidism, we basically provide thyroxine level, and in hyperthyroidism, we use one of this technique that increase the level of iodine that actually blocks the iodine organification step, which ultimately impact on the thyroxine. So this was the simple point is that regulation of thyroid gland is being controlled by the use of iodine. That's the point number two. Point number three is about the thyroid metabolism. It has three major steps for the metabolism. First one is the deiodinization, then conjugation, then excretion. Point number four is about the TSH. The TSH is also known as thyroid stimulating hormone. It is released by the pituitary that signals our thyroid gland to produce to increase the production of thyroxine when there is requirement in the body. Point number five is about the thyroid interactions. Thyroid interacts with the anticoagulants, insulin as well as cholestyramine. First of all, let's talk about how it interacts with the anticoagulants. Thyroxine level increase the chances of when you can say thyroxine level enhance the effect of anticoagulant. And how do it enhance that thyroid hormone decrease the potassium depletion, or you can say potassium dependent clotting factor, thus potentiate the effect of warfarin. For example, if patient is already warfarin user, then you give him higher dose of or simple increase the dose of thyroxine, then both will act synergistically, and you can say anticoagulant action will increase. There will be chances of hemorrhage. Similarly, there was also in the CVS chapter when we will talk about CVS chapter. There is a concept I will let you know that there is a comparison of table that in a hypothyroidism and hyperthyroidism, a patient who is affected by who is suffering from hypothyroidism, there is one of its risk is clotting, and when same patient is going to the hyperthyroidism situation, then there is a chances of raised INR value, then there is a chance of bleeding. So thyroxine level you can say enhance the effect of anticoagulants. So thyroxine anticoagulant should be very carefully should be joined in one prescription very carefully. So INR value and blood clotting factor must be kept in monitor while using this combination because it produces a synergistic effect. Similarly, second interaction is with the insulin, and it actually thyroxine antagonize the insulin, and it increases the requirement of hypoglycemia. Simply when the insulin action is antagonized, and blood sugar level will raise, then there will be need an alternative approach for the management of blood sugar level. Third interaction is the cholestyramine cholesterol, which is one of the very common interaction that whenever you will see cholestyramine cholesterol, mostly it inhibits the absorption of our drugs. Same case is happening here. The cholestyramine decreases the thyroxine absorption, so ultimately thyroxine level will drop. So these are the three interaction. Point number five, and let's move on to our next point. That is the point number six. It is about the thyrotoxicosis. As you know that thyroid storm, this is a sudden onset of thyrotoxicosis, is also known as thyroid storm. And thyrotoxicosis is actually increased the level of thyroxine in our body. So it is actually, or you can say in other words, it is also known as hyperthyroidism, which is being treated with the use of you can say PTU, that is also known as propyl thiouracil as well as carbimazole. These are the two drugs which play a very important role for the management of hyperthyroidism or thyrotoxicosis. And you can say PTU has another point relevant to propyl thiouracil, that it acts between 6 to 7 hours, and if we give 100 mg single dose, which can inhibits the organification by 60% for 7 hours. So its duration of action is between 6 to 7 hours, and 100 mg single dose can you can say work for 7 hours, and it actually controls the level of hyperthyroidism up to 60%. Similarly, there is another drug that is known as carbimazole. It is converted in vivo into methimazole. Methimazole is you can say 30 mg exert antithyroidal effect for you can say for 24 hours. But point here is that this PTU, that is also known as propyl thiouracil, is more effective and than that of carbimazole. So 30 mg dose of methimazole. That is also, you can say, in vitro carbimazole converts into the form of methimazole. So active the PTU is more, you can say, prioritized over methimazole because it is more effective than that of, you can say, carbimazole. So sorry, I would like to clarify this concept once again here, that just because I think you are confused because of I made you confused because I joined two concepts. So rather than going to mentioning the term of carbimazole, I will simply say that methimazole. Methimazole 30 mg dose exerts antidiarrheal effect, and it controls for 24 hours. But on the other hand, propylthiouracil 100 mg single dose controls the level of, or inhibits the organification by 60% for 7 hours. So propylthiouracil is more important, more effective than that of this methimazole. So let's move on our next point. That is about the thyroid preparation. When this preparation is required after surgical removal of thyroid gland, and its dose is 1.6 mcg per kg per day. And let's talk about the next point. That is about the you can say, thyroid gland uptake. You can say thionosinate affect uptake of iodine in thyroid gland. So by use of thionoside, if it affects the uptake of iodine, then whenever any factor which varies the level of iodine, it will affect the production of thyroxine. So thionosinate affects the uptake of iodine and in thyroid gland. So ultimately it will impact the production of thyroxine. Next, point number 14 is about the, as I told you, point number 14 is again repetition of that, is the propylthiouracil is preferred over carbimazole because although both are used in hyperthyroidism or thyrotoxicosis, but PTU is preferred over carbimazole. Point number 15 is about the euthyroids. Euthyroid. Whenever you listen to this term or read to this term, euthyroids, it actually indicates that normal thyroid level is also indicated by this term, that is known as euthyroids. Point number 16 is about the mixed edema. Mixed edema is decreased secretion of thyroid hormone in adults, and it is also known as hypothyroidism. For in that case, we can say exclusively use T4 level, that is the T4, that is also known as tetraiodothyroid, or commonly available in the pharmaceutical preparation. Its name is levothyroxine, or T3, that is the lenothyroxine. And mixed edema can be caused by the lithium and amiodarone. Lithium, although lithium is rarely causes one of the causes of mixed edema, but amiodarone is one of the major causes of mixed edema. Side by side, it also inhibits the production metabolism of levothyroxine to the lenothyroxine, that is more potent than that of levothyroxine. Now let's move on our next point. That is the point number 17, and it is about the methimazole. And methimazole, as you know, that carbimazoles at conversion, you can say, carbimazole is converted into the form of methimazole in vitro. So just keep in your mind that methimazole in pregnant women causes agranulocytosis. Then you can say the level of WBC drops in units, because in pregnant women specifically, when you will use in pregnancy, it causes agranulocytosis. This was at that point. Point number 18 we have already discussed about, that is actually about the thyroidectomy. We will discuss it before when we was talking about the regulation of a thyroid gland with the help of iodine, and in which we talked about Logos solution as well as potassium iodide. So I think so it is enough for today. In upcoming video we will record the remaining part of this hormone, and then we will jump towards the next gland that is that comes under the endocrine system. So thank you so much, professionals, for listening me. And if you feel that my effort is suitable for you, then please share my videos with your friend, and subscribe me. Your subscription is very important for my appreciation. Stay healthy, stay tuned.